Hello, today our group would like to present to you a mental health case study on suicide, depression, and substance abuse. Depression, suicide, and substance abuse facts. 1 in 6 people experience a depressive episode during their lifetime. Only 50% of people who meet the criteria for a diagnosis seek treatment. Females are more likely than males to experience depression. 23.5 million persons aged 12 or older needed treatment for an illicit drug or alcohol abuse problem in 2009. Between 2004 and 2006, 7.1 of the U.S. veterans met the criteria for substance abuse use disorder. Approximately 18.5 of service members returning from Iraq or Afghanistan have post-traumatic stress disorder or depression. Our patient is a 27-year-old male admitted to the hospital for substance abuse disorder. Patient is a veteran who was honorably discharged from the Army 6 months ago for medical issues. He served 2 years in military before being injured in Iraq. Patient lost his left leg in an amputation above the knee and suffers from back pain due to herniated disc. Patient has a remarkable patient history with exclusion of the above conditions. Patient has chronic pain syndrome and phantom limb pain. Patient family history is unknown due to closed adoption at birth. He also has depression with suicidal ideation. Patient presents with polysubstance abuse, opioid use disorder, and alcohol use disorder with post-traumatic stress disorder.
Hello, I am Kanisha and I will be presenting the first stage of the case study. So I'm going to start off with some nursing interventions. So I'm going to be switching back and forth between my face and my laptop screen so that you can see the PowerPoint and see my face, but you'll hear my voice in the background. So the first thing here is the nursing interventions. So we want to monitor our patient for signs and symptoms of detox, including taking his vital signs every 2 hours. We want to monitor him every 15 minutes for safety and comfort. Administer detox medications per the physician's orders. So questions for stage 1. What medications do you expect to be included in the physician's admission orders and why? And what is the rationale behind the use of these medications in the treatment of this patient? So here is a list. I'm going to try to fit it all on my screen here. A list of physician's orders on admission. So this is a detox protocol list for medication. We have Suboxone 4 milligrams sublingual daily times 2 days. Then we have 2 milligrams sublingual daily times 2 days. And then we're going to discontinue this medication. We have Depakote 500 milligrams 3 times a day for 3 days. Depakote 250 milligrams twice a day for 2 days. Then we have Depakote 250 milligrams daily. Then we're going to discontinue this medication. Then we have a multivitamin daily, thiamine daily. Both of those are for deficiency. Then we have triazidone at night for insomnia. Vistaril, 50 milligrams by mouth every 6 hours, nightly as needed for anxiety. And then we want to check his CBC and CMP, check his urine, B12, TSH, RPR. And then we also want to place the patient on suicidal and fall precautions to make sure, of course, for his safety. So the rationale for the questions. Opioid agonist-antagonist drugs can produce an abstinence or withdrawal syndrome by blocking the opioid receptor and preventing the effects of any agonist, like morphine, that may be in the body. So that is it for stage 1. Yoko will present to you stage 2.
So stage 2, during the day 3, patient attended an AA meeting and another patient in the meeting clapped their hands loudly. Patient began to yell at the patient that caused the loud noise. Both patients engaged in a fist fight. A code gray was called and the patients were separated. Debriefing of the situation revealed that a flashback for the patient that was triggered by the noise. The orders from physicians. EMDR therapy was initiated and cognitive behavioral therapy got started, and the treatment team reviewed and revised the treatment plan, and they added aggression precautions and increased Minipress 2 mg PO nightly for his nightmare, and Prozac 20 mg daily, and Zoloft 100 mg PO daily. So the patient in our case study is a former army and he was in Iraq. PTSD is an anxiety disorder that can happen after experiencing a traumatic event, like 9/11, Hurricane Katrina, and Iraq. Those events have been enabled researchers to learn a lot more about PTSD. And many researches are conducted to find effective treatment of PTSD, and most of those treatments are developed by mainly psychologists. And one of the treatment here is called EMDR therapy. It is the therapist will guide the clients to make eye movements or follow hand taps at the same time the patient are recounting the traumatic events. And another one for the medication, SSRI2, in particular Paxil and Zoloft, have been approved by the FDA for use in PTSD. And the therapy is the cognitive behavioral therapy. It's called CBT. Research shows that it is the most effective type of counseling for PTSD, and therapist helps patients to understand and change how they think about traumatic event and its aftermath. And it is designed for patients to identify negative behavior and learn ways to cope with feelings such as anger, guilt, and fear. So here's the stage 2 questions. As previously discussed, which medications are approved by FDA to treat the PTSD? The answers is Paxil and Zoloft for that. And another question is what type of therapy is the most effective to treat PTSD? And answer is cognitive behavioral therapy.
Stage 3. Although patient continues to make progress both mentally and physically, the patient's insurance will no longer cover his detox status. The patient's suicidal ideation precautions are discontinued after evaluation from the psychiatrist revealed him to be at no suicidal risk. The medical doctor gives clearance for discharge. The patient is given follow-up for appointments, prescriptions, AA meetings, scheduling, and sent to rehab facility for treatment. Stage 3, discharge orders. Patient will be given propranolol, 10 milligrams 3 times a day for his anxiety and hypertension, lidoderm patch topically for pain, Robaxin for pain, Prozac for his anxiety, folic acid as an additive, Zoloft for depression, Synthroid for additive, Prazosin for nightmares, Remeron will be given for nightly insomnia, Trazodone for nightly sleep, Vistaril will be given for anxiety, Gabapentin will be given for neuropathy, Camprel will be given for cravings, and he will be also forwarded for inpatient 28-day rehab program. Nursing interventions would be to advise the patient on storage of and use of the medications and side effects. Also, we need to arrange transportation and follow-up visits with the psychiatrist, the medical doctor, and chemical dependence meetings. And also, you may want to discuss options for the patient to make lifestyle changes for self-empowerment and participating in activities such as finding a new hobby or fishing or etc. Stage 3 questions. What do you expect the patient's long-term compliance and his sobriety plan to be? Another question is, what do you think are some of the factors that contribute to relapse in individuals with chemical dependency? And the answer to those questions are listed here. Drug and alcohol rehab statistics show that the percentage of people who will relapse after the period of recovery ranges from 50 to 90%. Network of friends and family members who abuse or provide access to drugs, impatience, depression, complacency, lack of discipline, etc.
So in conclusion, Our patient attended and successfully completed the 28-day inpatient rehabilitation program as ordered by the physician. He will continue use of all psychiatric medications and to see the psychiatrist on an outpatient basis. Patient will continue EMDR therapy for post-traumatic stress disorder. Patient states, I am motivated to maintain my sobriety and utilize the resources available to confront my mental health issues.